Welcome to the second paediatric session of the conference. My name is Kevin London. I'm just standing in for Professor Howman Giles. So I'll be a bit of a double act, helping to co-chair the session and also giving one of the talks. And I'd like to introduce my co-chair, Barry Shulkin from St Jude's in Memphis.
Thank you, Kevin. I'm actually standing in for Kevin as he moved over to Rob's seat.
So another excitement-packed session, but I would like to just reiterate that I think in the room here we have a large proportion of the global knowledge in paediatric imaging with molecular imaging. So it's of no mean feat that we've managed to pull in the speakers that we have from both locally and overseas, and it really complements the session that was before the afternoon tea, so we should really acknowledge that. So first up, I'd like to invite Meg Parisi from Seattle Children's. She's known to most of us in the room and has published widely on most aspects of paediatric nuclear medicine. She's been invited to enlighten us on PET-CT in paediatric non-oncologic conditions. Thanks, Meg.
Thanks again for inviting me. I'm delighted to be here. I don't have any disclosures or conflicts, and hopefully, can they dim the lights a little? I'll come over here maybe. I think that's better. So hopefully by the completion of this presentation, you should be able to list several non-oncologic applications for FDG PET or PET-CT, list an advantage and a disadvantage for performing PET or PET-CT for the evaluation of infection or inflammatory processes, and summarize the respective roles of FDG PET or PET-CT compared to anatomic and conventional nuclear imaging modalities when assessing the child with fever of unknown origin. As you know, tumor imaging remains the most common indication for the performance of FDG PET-CT, but in recent years there's a growing body of evidence which comes from the adult literature suggesting that FDG PET or PET-CT has an important role to play in the diagnosis of a variety of infectious processes, including fever of unknown origin and febrile neutropenia, for pulmonary infections or other inflammatory processes, for inflammatory bowel disease and musculoskeletal infections. And how does it work? Well, similar to malignant cells, activated inflammatory cells use glucose as an energy source, so there's going to be high FDG accumulation in sites of infection or inflammation. And on the molecular level, this is due to overexpression of glucose transporter 1 receptors in stimulated macrophages, neutrophils, and lymphocytes. So in adults, you can see the laundry list of the infections that FDG accumulates in, but in children, FDG uptake has been reported in osteomyelitis, inflammatory bowel disease, and chronic granulomatous disease, and in FUO, in addition to a smattering of other things such as aspergillus and candidiasis. There are several advantages to performing FDG PET and PET-CT, including high spatial and contrast resolution, high sensitivity for chronic infections, the fact that its performance involves minimal labor intensity, imaging times are short, so you quickly get your results, and there's high inter-observer agreement, as well as a much lower patient radiation dose compared to gallium or labeled white cell scanning, or prior modalities for evaluating infection. And here's a comparison of low-dose PET-CT and gallium tumor imaging. Additionally, FDG PET or PET-CT is not adversely affected by the presence of metallic hardware. FDG uptake normalizes rapidly following traumatic or surgical fractures because fibroblasts predominate during the healing process. And lastly, FDG accumulation quickly subsides within about 3 to 4 months following surgery. But most important to remember that you cannot use FDG PET or PET-CT to reliably distinguish between infectious from non-infectious inflammation or from malignancy. And in children, of course, another disadvantage is the need for sedation. So here, they look better on the screen, that's for sure. So here's the anterior images from whole body gallium and the MIP images of the torso and a whole body PET-CT in an 11-year-old girl who presented with fever and night sweats and weight loss. And as you notice, there's abnormal uptake in the left anterior mediastinum worrisome for lymphoma, but biopsy confirmed that this was histoplasma. And while both modalities are sensitive, PET has superior spatial resolution, and quickly you can get your results, so definite advantages. Another few examples, this 12-year-old had supraclavicular and axillary lymphadenopathy, underwent their PET-CT, and as you can see, there definitely is abnormal uptake. Biopsy showed suppurative lymphadenitis, and serology showed increased IgG and IgM titers for Bartonella, the organism that causes cat scratch disease. This 21-year-old female with 2 months of fatigue and a palpable neck mass underwent FDG PET, and you can see abnormal uptake in multiple cervical lymph nodes. Biopsy and serology confirmed a diagnosis of EBV mononucleosis as opposed to lymphoma, which was the reason the patient went to get their PET scan in the first place. This is another case, staging whole body PET in a 14-year-old with newly diagnosed nasopharyngeal carcinoma. We see uptake in the primary mass and in adjacent nodes, but whole body imaging demonstrates abnormal increased uptake throughout bowel. That was secondary to C. difficile colitis. One last example, this 5-year-old with non-Hodgkin's lymphoma underwent FDG PET, and you can see innumerable foci of abnormal uptake in skin, in lungs, in liver, and in spleen due to candidiasis. What about fever of unknown origin, which is defined as an illness lasting more than 3 weeks with a fever above 38.5 and no diagnosis after a week of either inpatient investigation or outpatient investigation that includes abdominal CT? About a third of the cases are due to infection, 20% to rheumatologic, autoimmune, or inflammatory or granulomatous conditions, 10% to neoplasm, 5% for some weird thing, and 30% remain undiagnosed. So these patients should all undergo a comprehensive history and physical, as well as a large variety of screening evaluations. MR, CT, other radionuclide evaluations, and more invasive procedures have been shown to be most helpful when available information suggests that there's some pathology to be further characterized. So early evaluation of 109 children with FUO by Steele et al. In the early 90s found that they could confirm a diagnosis in only a third. But these 109 children underwent 123 imaging procedures with only 17% of the imaging procedures positive, so we have to do better. Bonomo and Trevis evaluated 30 children with FUO using gallium-67 and came to the conclusion that gallium was rarely useful in children with FUO and systemic complaints alone, but may be useful if localized disease was infected because they only had 4 out of 30 or 13% positivity in their scans. What about fluorine-FT and FDG PET or PET-CT? Well, sensitivities have been reported ranging between 81 and 97% with high specificities and a very high overall accuracy compared to gallium-67 SPECT or indium-labeled white cells. Furthermore, FDG provides more sensitive information than either gallium or indium, and also does so within a few hours so with little labor intensity compared to those other modalities. And that finally, when FDG PET or PET-CT is negative, one can exclude clinically important infections requiring the use of prolonged antibiotics. And the use of FDG PET or PET-CT can help prevent the performance of unnecessary invasive procedures trying to find a cause for the fever. There have been several meta-analyses. One by Howe in 2013 looked at 15 studies, including the one pediatric paper, and found that there was pooled sensitivity of 85% for FDG PET and fever of unknown origin. A more recent meta-analysis of FUO in adults looked at 13 review articles. 9 studies looked at FDG PET in about 400 adults. 10 studies looked at FDG PET-CT in another 400 adults. And the conclusions were that both techniques were valuable tools in the evaluation of FUO, but that PET-CT was more helpful than PET alone, related to diagnostic information provided by CT. A more rigorous meta-analysis by Takuchi looked at test performance, diagnostic yield, impact on management, not only of FDG PET or PET-CT, but gallium and labeled white cells in 42 studies of almost 2,100 patients. And you can see below the results that FDG PET-CT had the highest sensitivity, a modicum of specificity, but a good diagnostic yield compared to the other modalities. What about children specifically? The earliest study was by Sturm et al., looking at 11 kids with biliary cirrhosis and FUO who were awaiting liver transplant. They used FDG PET and found some focal positivity within the liver in 5 of their patients. And in each of those 5, the lesions were confirmed either histologically or structurally to represent infection. There were no false negatives. Here's an example. Thank you, Kevin. This 11-year-old boy with previous liver transplant and ongoing fevers underwent FDG PET, and you can see, focal FDG avid focus in the liver that, when cultured, grew a variety of nasty organisms. Jasper et al. Looked at 47 FDG PETs and 30 PET CTs in 69 pediatric patients, the largest study to date, who either had FUO or unexplained signs of inflammation without fever, and found that the final diagnosis could be established in 54%. 82% of their PET scans were abnormal, and 45% of those abnormal were helpful in either excluding or allowing targeted investigations. When the scans were helpful, they could make a final diagnosis in 77%. And in those 54% with final diagnoses, the scans were contributory in 73. A more recent study by Blokis et al. Looked at FDG PET in 31 pediatric patients with FUO, and their numbers were similar. Final diagnosis could be established in about half, with high sensitivity and specificity. They looked at a subgroup of 12 immunosuppressed patients within this group and found that they could make the final diagnosis in 75%, and that 58% of the scans were helpful in patient management in the immunosuppressed patients, compared to only a third of those with FUO alone. Yang et al. Looked at FDG PET-CT in the immunosuppressed pediatric transplant patients with FUO. They did 41 scans in 18 patients. Only 1 patient was scanned prior to their transplant. And they found that the FDG PET or PET-CT suggested PTLD, which was confirmed pathologically in 11, and identified the cause of FUO in an additional 2 out of 5 patients, so fairly robust results. And here's an example. This 6-year-old ventilator-dependent patient with tracheostomy had fever of unknown origin, and you can see on the fused PET-CT that there is marked FDG avidity consistent with multifocal pneumonia. Tracheal aspirates were positive for methicillin-resistant Staph aureus. And another case, thanks to Kevin London, of a 13-year-old boy with prolonged fever, rash, and myalgias. And you can see here that there's abnormal uptake in the right ventricle, an ultimate diagnosis of pericarditis. What about FDG PET and febrile neutropenia? As you know, infections are one of the most common causes of morbidity and mortality in the pediatric cancer patient. And the absolute neutrophil count is the single most important determinant of patient susceptibility to infection. Febrile neutropenia is defined as a fever with ANC below 500 white cells or below 1,000 in those who are expected to become even more neutropenic after a course of chemotherapy. So let's look at some of the literature on that. Guy et al. Used FDG PET-CT and found that that imaging modality identified additional infectious foci plus all foci previously identified by conventional imaging in a prospective evaluation of 20 febrile neutropenic patients with hematologic malignancies. Coe et al. In a retrospective review used FDG PET-CT to evaluate 37 febrile neutropenic patients with hematologic malignancies and compared them to a cohort of 76 patients matched according to not only hematologic malignancy and duration of neutropenia, but these patients did not undergo FDG PET-CT. And their conclusions were a source of fever was significantly more often identified in those who underwent the PET-CT exams, and that antibiotic use was lower in the FDG PET-CT group. Voss et al., in a recent meta-analysis of 8 studies in over 150 patients with febrile neutropenia, concluded that FDG uptake in inflammatory foci was not hampered by the lack of circulating neutrophils, and that the very high negative predictive value of FDG PET-CT in excluding the presence of focal infection impacted patient care in this population. Even though it hasn't been used extensively in pediatrics, it's very promising for the children that we evaluate many times with CT or other modalities to look for the source of their fever. And one more clinical example, a 3-year-old with neuroblastoma and fever, and negative MIBG scans, underwent pre-bone marrow transplant evaluation, and you can see that there's an abnormal FDG focus within the right lobe of the liver, which was biopsy proven to represent an involuting abscess. How about the use of PET-CT in pulmonary infections? In a seminal article by Bamanji et al., high degrees of FDG PET uptake were identified in pulmonary infectious conditions including pneumonia, cryptococcus, aspergillus, and candidiasis, and in TB where, in the lung parenchyma, FDG uptake in tuberculous lesions varies according to the grade of inflammatory activity, as well as high degrees of FDG uptake in inflammatory and non-infectious conditions including sarcoidosis, which occurs much more frequently in adults, and cystic fibrosis, where it was found useful in measuring the inflammatory burden in these patients. They also found that FDG PET-CT was useful in monitoring response to therapy in sarcoid, in aspergillosis, in pulmonary toxicity and disease activity in bleomycin-induced pneumonitis following therapy for Hodgkin's to distinguish between active infection and residual scarring, and that it could also be used in the lung transplant recipient to distinguish infection, which is FDG avid, from acute rejection, which is not FDG avid. But they concluded that although the use of FDG PET-CT had high sensitivity for infection and inflammation, it has poor sensitivity and cannot distinguish between infection and malignancy in the case of FDG-avided mediastinal or hilar lymphadenopathy, and you often need histologic confirmation. Let me show you a few cases. This was a 3-year-old with neuroblastoma and suspicion of recurrence following chemotherapy and surgical resection whose MIBG scan was negative. So FDG PET was obtained, and there was no evidence of recurrence, but as you can see, there's FDG uptake in multiple pulmonary nodules with somewhat of a tree and bud appearance, and the diagnosis was metapneumovirus pneumonia. Another really great example, this was the staging FDG PET in an adolescent patient with newly diagnosed distal femoral osteosarcoma, so we do see FDG uptake in the primary lesion, but look at the lungs. There's FDG uptake in hilar nodes as well as several pulmonary nodules. Also notice the markedly increased FDG uptake in the diaphragm, which was actually due to increased work of breathing. And this patient had varicella pneumonia. If you look carefully, you can see uptake in the skin lesions as well. What about PET-CT and inflammatory bowel disease? Well, those of us who are radiologists know that MR enterography has eclipsed the use of radiolabeled white cells for inflammatory bowel disease because it's easy and there's no ionizing radiation. We know that FDG PET-CT is superior to labeled white cells and even to monoclonal antibody scintigraphy for inflammatory bowel disease, and that in children it's been proven to be highly sensitive, specific, and accurate in diagnosis and in follow-up of IBD. Signori et al. Has suggested that PET-MR is superior to FDG PET-CT because of superior anatomical and soft tissue detail, the benefit of MR diffusion-weighted imaging, and lower patient radiation exposure. And we had recently this very unusual case of a 14-year-old presenting with multiple pulmonary nodules and back pain who underwent FDG PET for a suspected malignancy. And FDG uptake was present in the lung nodules and in the cecum and in the ascending colon, and you can see diffuse bowel wall thickening. This patient had Crohn's disease with rare pulmonary involvement. I'm briefly going to talk about MSK infections, and it's been shown that FDG PET or PET-CT is highly sensitive for the diagnosis of both acute and subacute bone, as well as soft tissue infections with sensitivities of 98% and high specificities, but is of limited value in diagnosing uncomplicated osteomyelitis compared with a combination of physical exam, evaluation of biochemical markers, and 3-phase bone scan, especially in children who frequently have the need for sedation. In adults, however, FDG PET or PET-CT is the imaging procedure of choice in chronic osteomyelitis, where it's highly effective, highly sensitive, and very accurate, with even greater specificity than any of the other agents, including gallium, indium, bone scan, or MRI. So here's some examples. Here's an FDG PET obtained in a child who had hip pain, a bone scan showing abnormal uptake in the right second rib, which is also positive on FDG PET. This turned out to be chronic recurrent multifocal osteomyelitis. And here's a case of a 12-year-old with a painful right arm with diagnosis of chronic osteomyelitis. Remember that FDG uptake is nonspecific and in children especially can be seen in a variety of inflammatory processes like Osgood-Schlatter's, plantar fasciitis, or ostrigonum syndrome. A few other non-oncologic applications. We don't do very much cardiac PET-CT in children, but there's definitely a role. And you can see the using the combination of perfusion imaging with either nitrogen or rubidium, as well as FDG, you can assess perfusion, function, viability, inflammation, anatomy, and perform risk stratification. I want to talk just briefly about the non-FDG PET tracers, which include sodium fluoride, which can be used in children or has been used in the setting of trauma, including for the assessment of low back pain and non-accidental trauma. Sodium fluoride has similar uptake pattern but superior pharmacokinetic characteristics compared to MDP. F-DOPA has been used to diagnose congenital hyperinsulinism, the most common cause of severe hypoglycemia in neonates and infants, whose long-term outcome is dependent on effective prevention of these hypoglycemic episodes, which can result in brain damage. Now, there are a variety of treatments, the standard being near total pancreatectomy, but in kids, between 1/3 and 60% of neonates have the focal rather than the diffuse form of congenital hyperinsulinism, so limited pancreatectomy can lead to complete cure. And F-DOPA is accurate and a non-invasive technique to differentiate between these two types with high sensitivity. And we'll hear more about that later in the conference. And then the potential role for gallium-68, a generator-derived positron emitter that's been used successfully in adults for the imaging of infection and inflammation in both preclinical and clinical settings. Its advantages compared to gallium-67 include a shorter half-life, improved and expanded labeling choices, shorter imaging times and improved dosimetry, and higher quality imaging compared to gallium-67 SPECT. So in conclusion, FDG PET or PET-CT can be pivotal in the detection of infection and non-infectious inflammation. While highly sensitive, it's nonspecific and cannot be used to reliably distinguish malignancy from infection or non-infectious inflammation, and biopsy of other types of histologic confirmation is necessary to confirm a diagnosis. We'll hear about epilepsy later in the session. We've talked minusculely about cardiac and some of the other non-FDG radiotracers. And I want to leave you with this last thought, that children are not small adults. They're more sensitive to radiation than adults and have a longer lifespan in which to develop radiation-induced injury. So remember to image gently and go with the guidelines and use pediatric-specific radiopharmaceutical administered doses, and optimize your imaging and reduce dose by pediatric-specific protocols. Some references and resources. Thank you very much, and I'm sorry if I talked a little fast there.
Gracias. The last slide. Any comments or questions from the floor before Meg runs down to retake her seat in the audience? I think in the lieu of questions, I'll make a comment that we're finding FDG PET for fevers of unknown origin in children useful but challenging in trying to analyse them in a meaningful way, given that it's such a heterogeneous group of patients that we're trying to scan and provide useful information for. It's hard with musculoskeletal infection, high-risk patients, ICU patients, and then your garden variety, inverted comma, well child that's just had a fever and can't find a focus.
Well, I think compared to a 33% success rate for all the other modalities, bumping up to 52% or even higher is, especially in the patient with febrile neutropenia, I think is a big plus, because how many repeat CTs do we do in these patients looking for fungal infection? And we know from publications by Dr. Sakridge, and I'm not going to say the name right, but Anna from the Netherlands, that FDG PET is is superlative for identifying and being able to follow response in fungal infections.
Thanks, Meg.
Thank you.
My pleasure to introduce Dr. Kevin London, Westmead Children's Hospital, who is going to educate us on PET in pediatric neurology and neuro-oncology.
Thank you, Barry. I just want to mention that I have no financial disclosures, unfortunately. And there are some clinical images here for which the patients have given consent for them to be used in educational meetings, and also I acknowledge some slides that have been provided by other clinicians. So I've broken it up into two sections, and given the limited time, we'll skip briefly through some aspects, although I'll start with neurology in general and then move on to neuro-oncology. You can't escape without talking about normal patterns of cerebral FDG uptake during childhood, epilepsy, and something that's on the horizon, hopefully, that could potentially help a lot of patients is not just FDG PET, but other PET traces in pediatric neuroinflammation. So this is a slide that most of us have seen in textbooks for quite some time and still comes out. And Harry Chugani back in the 80s sort of described this pattern of FDG uptake reaching an adult pattern, in inverted commas, by 1 year of age. And this is based on some data, mostly in neurologically abnormal children. And that's incorrect. And we showed that there are in fact linear changes that happen in different regions of the brain throughout normal childhood development. And this slide does highlight some of those regional differences. In that in the younger children you have relatively reduced intensity of FDG accumulation in the frontal lobes compared to the parietal occipital regions, which then as you get older into adolescence, it switches so that the parietal occipital lobes are less intense, and believe it or not, adolescents have surprisingly high activity in their frontal lobes. What does this mean for us? Well, part of the work that we produced showed this trajectory of different regional areas of FDG accumulation, different parts of the brain, and this looks a bit odd. Parietal lobes reducing in relative intensity as a child gets older. And remember, these are qualitative views when we scale the image to the most intense part of the cortex. And Barry's group soon after found a similar pattern when they did a more sophisticated parametric analysis, showed that this graph shows that most of the parietal lobes show a similar reducing pattern of relative intensity as the child ages. So it was quite nice that two different centres, two different data sets, two different types of analyses showed similar results. Not to be confused with absolute rates of glucose uptake in the brain. These different regional patterns really come about because of the different rates of increasing uptake. When a neonate is looking at you, they have very low absolute rates of glucose utilisation in the brain, much below an adult. Throughout childhood, the absolute rates of glucose uptake increase to peak at about 9 years of age, about twice that of an adult, and then sadly decline after that. So the different relative patterns we see result because of this slightly lower trajectory of increase of the parietal and occipital lobes. And this is the image I showed before. Now that's all fine and dandy, and something that I've been trying to get a handle of is using this sort of data set for statistical parametric mapping. An awful name for a complicated statistical analysis where PET brains can be spatially normalised to the same stereotactic space, smooth with some fancy statistics, then used to track voxel by voxel changes in relative uptake depending on whatever covariate you put in. And in our case, we like to see the changes that occur with age. And when we do that, we can show that using this more sophisticated analysis, that's showing the areas in red are those areas that show a relative increase in uptake as a child ages, matching quite nicely what we suspected based on the qualitative studies. And when you drill down to a particular voxel, this is a child's age going from 1 year to 17 years, This is the voxel response, or the uptake in that voxel as the child ages relative to whole brain. Now, don't be confused that these previous studies looked at children from age 1 and above. Hopefully it projects reasonably well. The neonatal brain is a whole different kettle of fish. There are markedly different regional changes that happen probably from birth up until at least 3 or 4 months of age. Let's move on to some epilepsy cases. Well, pediatric epilepsy is a serious issue. It's the most common neurological emergency in a child having a seizure, and the lifetime incidence of having a seizure is about 9%, 1/3 of which could be related to febrile convulsions, which are relatively common. It's a significant burden in terms of morbidity, in that children with epilepsy often suffer recurrent seizures if medically intractable, resulting in poor school attendance, failure to reach developmental potential, and also an increased rate of associated neuropsychological disorders such as depression. And there is this sudden death related to epilepsy which can happen, which continues to be a problem. This is a slide from the head of the epilepsy unit at my hospital, trying to summarise the paradigm for surgery, the approach to surgery in paediatric patients with medically refractory epilepsy. And to summarise a complicated slide, it involves multimodality assessment, trying to work out the site of a paediatric brain to resect is no mean feat, and utilises video EEG data, the semiology of the clinical seizure itself, neuropsychiatric assessment, MR to look for lesions, functional imaging with PET and ictal and interictal cerebral perfusion. And those of us in the room that have attended these MDTs know that they are long. One patient can take 30 minutes or more to cover. Okay, there are lesional causes for paediatric focal epilepsy. This slide just summarises a few of them. Medial temporal sclerosis, scarring, which can cause or may in fact be the result of an epileptogenic focus. Cortical dysplasias, of which in the paediatric age range are more likely to be extratemporal. And also sequelae to inflammatory disorders, of which Rasmussen's encephalitis can be a predisposition for a seizure focus. Part of the paradigm for surgery involves mapping the origin of the seizure focus, and in which case it can either occur via invasive intracranial monitoring, as you see here, where a grid of surface electrodes are laid on the surface of the brain, or more commonly in the more advanced centres, moving towards stereo EEG, or stereo electroencephalography. So this is where depth electrodes are placed through into the deeper tissue, with then awake monitoring occurring on the epilepsy ward over a period of a few days. Continuous monitoring trying to determine the origin of the epileptogenic focus for which to guide surgery. Here's a case to illustrate some of those points. An 11-year-old boy, cryptogenic focal epilepsy, thought to be arising from the left frontal area, both partial and complex seizures with some mild cognitive impairment. Cerebral MR showed some equivocal signal intensity change on FLAIR imaging in the middle cerebellar peduncles, but it was stable. Let's have a look at his semiology. So you'll notice that he's in the preictal phase. You can see he senses something. He's going to turn his head, whimpering, and you'll see this posturing of his right upper limb and this late head response with deviation of the eyes. Here he goes. You'll see all this action happening here is the epilepsy nurse injecting the cerebral perfusion agent, which in this case was ECD. So that's the tracer going in within about 20 seconds of the seizure onset. This is his ictal ECD, and to summarise it, if you glance through, there's one focus really in the left frontal region standing out as possibly representing where that seizure occurred. The interictal FDG scan, harder to read. If we look a bit more closely, you can see there's some subtle changes out the back here. With the aid of co-registration, part of this region of hypometabolism on the interictal PET localizes to this rather abnormal looking gyrus in the left frontal lobe. And when we register that to the ictal ECD, quite nicely localizes convincing evidence for a seizure focus arising from that zone. This patient went on to have a focal resection of that area. A cortical dysplasia was determined on histopathology, and he remains seizure-free. So everything lining up, good surgical outcome. Just some straight FDG scans to get your eye in for what we're looking for. A 16-year-old girl with temporal lobe epilepsy, and the MRI had concordant findings of right-sided hippocampal atrophy. Hypometabolism on this interictal FDG scan correlating to that side. Good outcome post-surgery. Here's a 3-year-old boy with focal seizures, but also a hemianopia. So already you're starting to think, based on the clinical features, this is an extratemporal epilepsy. Quite profound hypometabolism on this interictal PET in the occipital region. Non-lesional on the MR, however, I think this patient went on to have invasive monitoring, further localizing this region, had it resected, a type 2 focal cortical dysplasia, and a good surgical outcome. This is the last case in this set, 11-year-old girl with non-lesional frontal lobe epilepsy. The FDG scan was performed in the interictal state, and there's a little punched out area of hypometabolism in the right frontal lobe anteriorly. Previous MRs really showed non-specific findings. This is slightly more subtle than the other examples. Well, when we throw that FDG scan against our normal data set and ask the computer to show us on a voxel by voxel basis, is that statistically significant? Encouragingly, it does show us that, yeah, that area in the right frontal lobe does show reduced uptake when you normalise it and compare it against the data set allowing for age. But is that any good? You know, is it better than a qualitative read? Well, we analysed 61 paediatric epilepsy surgical patients using this technique. 47 of the patients that went to surgery had a good outcome. In other words, complete seizure freedom or a very good response. In other words, a much reduced temporal occurrence of seizures. And 14 had a poor outcome, so very minimal response. And suffice to say, using this technique to try and localise the resection margin, the sensitivity was not that good, but the specificity was quite high. In other words, if a patient is being contemplated for epilepsy surgery and an interictal PET can highlight that area with statistical mapping, it builds a good case for a good surgical outcome. Here's a case, again, showing the statistical mapping highlighting an area in the right anterior frontal lobe, which was subsequently resected, shown to represent mesial temporal sclerosis histopathologically with a good post-surgical outcome. A few other examples. How good is statistical mapping? You know, one of the criticisms of this type of technique, it's overly complicated and it's less sensitive than just reading it blind without the sort of quantification. Here's a more subtle defect. There is reduced uptake in the right mesial temporal structures on this FDG scan, supported by the statistical mapping. So the way I look at this sort of analysis is that it's similar to your polar maps when you're reading cardiac MIBIs. It's a good adjunct, but probably doesn't replace or do us out of a job. This one's a bit more subtle. A 12-year-old boy with focal facial twitching and secondary generalisation was seizure-free for many years, but then recurring seizures after a head injury. Who can pick the zone of hypometabolism? Bit tricky. It was for me. With the aid of the MR, it becomes a bit easier, and when you register it, it becomes even more obvious. There's an abnormal gyrus in the operculum on the right. If you ask the computer to try and help out, encouragingly, this level of subtlety does get picked up by this sort of statistical mapping. Hopefully you can see that image rendered on a 3D scale. Neuroinflammation. various types of autoimmune encephalopathies in adults have been shown to be shown on FDG PET with various regions of both reduced and increased uptake. Here's a child, a 7-year-old girl, presenting with an abnormal movement disorder. She also had progressive encephalopathy, that is impaired consciousness, dystonias, was a diagnosed patient on neurotransmitter analysis of an anti-NMDAR encephalopathy. This is her during one of these relapses. So you can see this sort of writhing choreiform movement. A frankly dystonic child, incredibly distressing and hard to treat. This is the FDG scan of that girl showing these quite large regions of hypometabolism, again showing statistical significance on the 3D parametric mapping. Another patient, a 5-year-old boy, similar behavioural change with this dyskinetic writhing movements and a progressive encephalopathy. The FDG scan here shows reduced uptake in the occipital lobes, and if we think back to what a 5-year-old child should represent in their brain with FDG uptake, a 5-year-old has no business having occipital lobes of this hypometabolic. And it's another case of an anti-NMDAR encephalopathy. And adult data has supported that this is becoming quite a specific localization sign for active channelopathies, of which anti-NMDAR is one of the causes. Now, I'm going to talk very quickly about neuroinflammation on one slide. Neuroinflammation assessment with FDG PET really is looking at the end process of neuronal dysfunction. What we're all waiting for is a really avid marker of neuroinflammation that can be applied in childhood. It's not available yet, but there's some interesting data using this agent, a GE180, which is a fluorinated translocator marker, and the signs are encouraging for multiple sclerosis, showing sites of inflammation. So maybe in the future this will be available in pediatrics. Neuro-oncology. I'm going to talk about FDG PET, FET, grading of lesions and determining residual D versus post-therapy effects. Pediatric brain tumours, second most common solid malignancy in children, often leads to severe neurological, neurocognitive and psychosocial sequelae and can have a dismal prognosis. The key point is that in adults, most primary brain tumours are high grade, whereas in children there's a larger proportion that are low grade, making it harder to detect, particularly with FDG. But this study coming from Copenhagen and Lissé Borgward shows that when analysed with FDG, there's a nice linear correlation with FDG uptake in these tumours in grade, with the high grade, that is WHO grade 3s and 4s, showing higher uptake than the lower grade lesions. These lesions in green are the pilocytic astrocytomas, which are a low grade lesion which curiously shows a very high FDG uptake, presumably related to its glucose transporter expression. This is one of their papers showing that it's imperative to have good MR co-registration or simultaneous data acquisition in the terms of PET-MR to try and determine the metabolism within the tumour itself. So on first glance you wonder, well, where is the tumour in this FDG PET scan? Clearly on the MR there's a cystic component with fluid and there's a solid component posteriorly which has very high uptake. And this was an FDG positive primary brain tumour in a child. Not to withstand that, the paper used a slightly complex algorithm to grade uptake in these tumours, where they scored a tumour FDG uptake of 2 if it was the same as white matter and 4 if it was grey matter. So if you extrapolate that to their graph, white matter uptake with their ratio of 2 forms about here, which means if you've got an FDG scan that shows tumour uptake above white matter, that puts in all of the high-grade tumours. Very hard to work out qualitatively. Some examples. This is a boy with a malignant pineal germ cell tumour, pre-therapy, evaluated with FDG PET, showing that the the enhancing tumour mass showed very avid FDG uptake. After surgery, the question was, does this represent residual tumour or is it post-therapy effect? And with the aid of co-registration, it becomes clear that that area of enhancement on the MR really doesn't show FDG accumulation above white matter, negative, and this most likely represents post-therapy effect. We all know FDG uptake in the brain, particularly to evaluate for residual tumour, is limited because of the high cortical uptake. This is where amino acid imaging comes in. The most clinically useful amino acid agent in children would be the fluorinated fluoroethyltyrosine. Carbon-11 methionine has been used before, and they have a similar biodistribution. Here's some examples from the literature. This is a patient that had a tumour within the right posterior parieto-temporal region. The FDG PET showed low uptake, whereas the FET PET clearly showed a good signal-to-noise ratio. Similarly, another patient with a primary tumour. This is the FDG uptake showing, yeah, it's got focal increase, but actually quite hard to pick on the MIP against the background activity, whereas you much better signal-to-noise ratio on the FET scan. And these were both cases of WHO grade 2 tumours. Here's an example of a clinical case, a 15-year-old boy with previous therapy for an anaplastic ganglioneuronal tumour. The MR, post-surgery, radiotherapy and chemotherapy showed the residual surgical resection cavity, but an area of enhancement just supromedial to the surgical site. The FDG scan, very hard to interpret because of the adjacent cortical uptake, but an FET scan showing quite clear signal-to-noise uptake with a ratio greater than 2. This is a follow-up MR scan showing progression of that lesion. It wasn't biopsied, but he went on to succumb to his disease. So although not biopsy proven, clinical follow-up confirmed that that was disease, residual disease. Another case, a 12-year-old boy presenting with a generalised seizure. MR showing a large tumour in the right posterior parietal region, had an incomplete resection elsewhere, and histopathology revealing an anaplastic ganglioma. So chemotherapy, radiotherapy with stem cell rescue. 18 months later, an MR shows new foci of enhancement. The question remains, is it post-therapy effect or could this be recurrence? So this is the case in question showing the surgical resection cavity. Now, an FDG PET, again, illustrating how difficult it is to work out, even with the aid of a good co-registration with a non-simultaneous MR, difficult to characterise uptake. An FET scan in this patient shows clearly abnormal uptake, not only surrounding the surgical resection cavity, but extending bilaterally through the white matter tracts. Same patient, just localising more of the abnormal FET uptake. Very abnormal and positive for diffuse gliomatous extension. So this is the patient's FET scan, and the patient succumbed with gliomatosis cerebri. And this is a stain looking at the extent of the gliomatous infiltration. And I'd like to say that this maps exactly with the FET, but it's there or thereabouts. But it's good histopathological confirmation of the FET signal. And it was gliomatosis cerebri. So the indications for FET PET, at least in our institute, would be to determine residual or recurrent malignancy after therapy, to determine the extent of the primary tumour when planning surgery or a biopsy, and to differentiate tumour from non-neoplastic MR findings, particularly in the subgroup of NF1 that can have non-specific T2 hyperintensities. FET kinetics may help grade the tumour. There's some data on that, but it's difficult to implement in practice. And tumour to background ratios have various cutoffs that can help in interpretation. That's the end, and I'm happy to take questions if there's time. In the interest of time, I think we'll move on. No, I'm not sure of the timing, but I think I might have gone over.
You Yeah,
Yeah.
buddy.
Do you use dynamic imaging and FET to help you differentiate between what's tumour recurrence and post-radiation necrosis or disease activity?
I'd love to ask you that, Tim, if you use it.
I'm using it, but I don't have an interpreter. So
We are using it only because we try and schedule our FET brain cases in such a way that we can acquire the dynamic data. And to answer your question, yes, we are. So we inject them on the bed, acquire in list mode dynamically, and then at 30 minutes, then do your sort of garden variety static acquisition. And we're looking at that data. It's tricky, and I alluded to that. We tried to experiment with different bins to try and map this dynamic phase as accurately as we can. And for the people in the audience that are thinking about FET dynamic profiling, there is information in the literature that says that low-grade tumours and high-grade tumours have different FET kinetics, such that low-grade tumours have a higher peak and then wash out, and low-grade tumours have a slowly rising peak. Happy to be corrected if I've mixed that up. But in practice, it's pretty hard to see. Noisy data, signal to background's not that great, and trying to work out this binning to analyse the dynamic data is difficult. And I think after speaking to the people in Copenhagen that published on that, they have experienced a similar finding. So I think there's been a little bit of a glut in the literature in the last few years as we struggle with that.
Yeah, so our experience, I mean, Peter's more experienced than I am, or Peter's neck on more than I am. But there are obviously different patterns, but I just don't think it's as clear cut.
Yep.
There's just been the early and late peaks.
Yep.
I was just interested to see what you or anyone else's experience was.
I wonder if Peter's going to have a brilliant slide on that showing all his great profiles. I'm not sure.
Not on that one, no.
Okay, but that's challenging.
We don't find that reliable.
Follow-up question on that is you said that you looked at the ratios. Do you do ratio what to what? Because that's a bit confusing in the literature.
Yeah, and I ask the question in conferences exactly in that way, and you'll find that you get different answers. I mean, when it's a lateral tumour, it's not difficult, I suppose. You take a contralateral chunk of the cortex. But some literature will take frontal lobe regardless. And the difficulty arises when it's a very midline tumour. Let's say you've got a brainstem lesion. Where do you take your background from? And I don't think we've got a good answer to that. Yeah.
Someone said that you could pair the white matter with the grey matter. I think, well, what does that mean?
With FET, yeah. I would usually take a bit of the cortex. Yeah.
Yes. Okay. And do you do delayed images?
With FET, no, just 30-minute uptake.
Yes, you
Yeah.
don't go to 45.
Although it's a 10-minute acquisition, so we get close. Okay, thank you. Oh, thanks for that question, Tim. I'm looking forward to your talk. Peter Francis. Peter Francis from the Royal Children's, and I'm just thinking about Tim, who asked the question before, who's also the head of the department there. So a very well anticipated talk from Peter, and I'll probably forget at the end, so I just want to congratulate both Peter and Tim for setting up the service. It's an incredibly complicated service to set up, with intersections with billing, radiologists, annoying nuclear medicine physicians. The reporting workflow must be a nightmare, but their experience has been superb, and they've really gone off with it with a hiss and a roar. So I know I'll forget at the end, so I just wanted to congratulate them on that. So without further ado, Peter Francis talking on his experiences with PET-MR.
Okay, thank you. Thanks for staying till the end of the day. And this talk will have some significant overlap with the first two talks, but we'll be talking about the PET-MR experience and the establishment of our service and what we have seen. We do have a declaration. So the Royal Children's Hospital is a global reference site for Siemens, and there is a research collaboration through the Children's Research Institute. Our hospital has a large Good Friday appeal, and we were lucky in that we had a large lump sum of money that was delivered to us to be able to establish this service. And it was, at that time, was going to be the first paediatric hospital in the world with a PET MR, but through administration and a bunch of other delays, we didn't quite make that first in the world, but we were close. This is our setup, and it's a paediatric-friendly environment, but with a small bore. And we have found the PET MR with the size of the bore quite challenging for our paediatric patients. When you're doing whole body imaging, which we do in infection and obviously many tumours, they are encased, and we've found that we've had to do a significant number of anaesthetic and sedation studies, more than we were expecting, and certainly more than Kevin described that they do in Sydney because of that. So there has been some obstacles and some challenges in our patients. It's a long imaging time. We have multiple coils. We have high levels of anxiety and claustrophobia with a large number needing sedation and GAs. And we, even within the epilepsy studies, which are shorter studies, we still have about a 25% rate of anaesthetisation requiring. So that's done after uptake. So we do anaesthetics for imaging, but they have had their uptake prior to this time. And they get hot, particularly with the long studies. So we put our scanner in about 2 years ago. We've now done more than 800 total studies, and we've had about 210 epilepsy studies in that time. It's operating as a pure clinical imaging modality, and it was done because we thought the PET imaging was mature, MR was mature, we had space constraints, we needed to improve our MR capacity, and the PET MR obviously has some nice synergy, so we chose to go PET MR alone, and we don't have PET CT. So this has given us many benefits. So we have simultaneous acquisition of the PET MR data with potentially no misregistration. We have single studies, single anaesthetics. We have a lower radiation dose, and I was going to take this out, but it's important to talk about our low dose. We give 2 megabecquerel per kilogram of FDG, which is about half of what many other centres do. And it's a sensitive detector, and it has good geometry, and we acquire for a long time, so we can get away with low dosages. And that leads us to having very small dosages, so 11 megabecquerels in a small child, and when we actually look at less than a millisievert effective dose for a 4-monther, going up to 2 to 3 millisieverts for the whole body studies. So we get whole body imaging with low radiation dosages, which is an important benefit for this technology. So our experience, talking about the more specific things, I'm not going to talk about oncology, but epilepsy. So as I said, we've currently got about 210 patients as of last week that have had epilepsy studies. And we did not mean to start quite as quickly as we did, but the clinicians overwhelmed us with referrals from the beginning, and where we used to send our patients off to the adult hospitals for studies, our main adult hospital actually removed their services as soon as we had a PET MR. And so that's one of the reasons why we've had so many studies so quickly. And because of that, we actually did not advertise for infection imaging. We were too busy trying to cope with the oncology and epilepsy studies, and we didn't encourage infection imaging to begin with. But as time's gone on, that's become more of a part of our practice. So with regard to epilepsy imaging, it's predominantly patients in the surgical program, and the surgical programs around the world have become more prominent, and recently there's been position papers that have been put out from the International League Against Epilepsy with a recent Australian guideline put out in the Medical Journal of Australia just a month ago on the management of epilepsy in children and adults, and the push is to actually encourage more patients to be referred referred to the surgical programs. And the reasons for that is that about 2/3 of patients who have epilepsy do become seizure-free with appropriate anti-epileptic drugs. And so the majority of patients can be managed medically without surgery. But if you do need more, if you fail an appropriate trial of an anti-epileptic drug and then you fail a second trial, your chance of becoming having decent seizure control and particularly seizure-free is less than 1 in 8. So if you fail your first 2 trials of medication and they're appropriate medications for your seizure type, you are likely to have ongoing seizures for life. And as Kevin talked about, that comes with a significant disability and mortality and morbidity cost. And so there's an increased push to try and identify patients that may be surgical candidates. And actually, before I move on, over the years, the general delay from time for those sort of patients to actually get to surgical programs is in the order of decades. And so if you have decades of ongoing seizures, that comes at a significant cost. So the aim of our imaging is to locate the epileptic focus, the eleptogenic zone, and try and determine the minimum amount of cortex that if you resect it or disconnect it or destroy it will probably result in seizure freedom and minimise the risk of post-operative mortality or morbidity in particular, and provide a surgical planning map and define the relationship of that lesion to other areas of important function. And so, again, as Kevin said, it's multi-modality. There's many investigations. There's the video EEGs, structural MRI, the FDG PET, functional MRIs, neuropsych assessments, possibly SPECT imaging with ictal and post-ictal SPECT. We do less of that now, and interoperative EEGs. So our standard protocol is to have them fasted, normal preparation. We take medication history, noting recent seizure patterns and recent types, make sure they're hydrated, check their blood sugar. We administer their 2 megabecquerels per kilogram and make sure they have a minimum of 30 minutes of uptake, and try and control their environment in terms of stimulation, not to have them too active. However, we do let them watch television or have books or stories read to them, and then we have imaging, and we have PET acquisition, and at the same time we have MR acquisition, where we have the T1, T2 sequences, the flare, and one of the great benefits of having PET MR is that we can correct against movement to the MR as it's acquired. And so we find that even in our anaesthetised small patients, when they're having respiratory movements, they get head bob just from breathing. And so we do motion correction on every patient that's under 15 kilos, and we do motion correction on patients that are awake who are that may have some behavioural issues, which many of them do, or beyond that. And sometimes the movement can be quite significant. You can actually see that these patients really can move around on the camera. And this is a 15-year-old who has attentional issues, who had a diagnosis of, oops, let's go back again. And you can see that that is not a particularly well-defined image, but with movement correction, we get much better demonstration of the sulci and gyri. We can see that you've got differentiation of the structures, and the movement correction, being able to apply it directly to the MR, is quite important in the quality of our studies. So here, this is an example of a 16-year-old girl who was functioning quite well. She was getting to the end of her high school, but she had nightly seizures. She'd had a past history of already having a small region of frontal cortical dysplasia resected 2 years earlier, which had initial seizure control, but then her seizures recurred. And just here, it was thought on the MR, a little bit of blurring, possibly a sulcus dysplasia. And you can see here, there's no PET, it's ametabolic. That sulcus is, hopefully that's projecting well enough that you can see that there's grey matter there with very little metabolic activity. And when you're looking at this, one of the striking things of this is that if you just looked at the PET images, it's actually not that asymmetric, but it's the lack of mapping of metabolic activity to that grey matter that allows you to provide sensitivity and specificity of the PET-MR. And she then went on to have a functional MR, which shows that she's got surrounding language all around it, but there's actually no significant function in that. So to have that base of sulcus dysplasia resected is unlikely to leave her with a significant morbidity. Another one, 9-year-old girl with focal seizures causing absences, and she falls. And aphasia, important, so you know it's within speech area. Again, a little bit of blurring, a thickened grey matter here, but really difficult to be confident about. But again, the PET, completely ametabolic. Her tractography demonstrates tracts going around that, but the three-dimensional PET shows a surgical corridor that can approach to actually have resection of that. Both of these girls have had their seizures at this stage under control after having these localised areas resected, but they're only a few months post-surgery, so it's too soon to be sure if it's going to be prolonged. A more significant one, a 10-year-old girl with focal epileptiform activity, which was predominantly from a right hemisphere, but the EEG was a little variable. She'd had several EEGs which didn't localise it fully. So this is her. I'm just showing a few seconds of this. So you can see up here that she's got frontal and temporal EEGs, parietal activity, but it all starts at once, so it doesn't localise exactly to where the seizure is. So she's sitting there, she has moving around, she then suddenly has changes in her posture and tone as she starts having seizure activity. But it doesn't localise exactly. So she went on to have her PET-MR. And again, hypometabolism, it's subtle if you look at just the PET activity alone, because you can miss it, but it's clearly hypometabolic over the grey area. So it means that we can demonstrate a significant area. This girl has not yet had her surgery, but of importance, her previous MRs have been reported as normal. But you can see that this fits with the region of her EEG and is clearly hypometabolic, and she is now heading towards surgery. And again, surface projection of the ametabolic area. So why do we do it? The outcomes are that these are published figures from the International League Against Epilepsy last year, that it's the most effective treatment for drug-resistant focal epilepsy, and with more than 50% of them having a significant improvement with becoming essentially seizure-free, compared to the 1 in 8 that would have that potential if they stay on medications alone. And a recent study from Webb et al., who looked at 80 patients, they showed that 60% of them were free of disabling seizures, still some with minor seizures, versus 3 out of 40 that had on anti-epileptic medication alone. So our neurologists are sending us significant work down this line. Infection, inflammation. As I said, we didn't start advertising for infection and inflammatory studies. The clinicians sort of found us by accident because we were trying to control our workload initially. And there hasn't been a lot of studies on PET-MR specifically to look at the outcomes. There has been studies, as Meg talked about before, on PET-CT demonstrating a significant improvement and helping the delineation of further investigations and deciding about what biopsy sites or cultures need to be taken, but because up to 50% of them may make the diagnosis, and 80% of them were considered abnormal that allow you to actually localise that infection. We had our oncology fellow did a local study looking at our oncology patients who had fevers for investigation, and found that this was based on FDG PET, but PET CT predominantly, before we actually commenced our service, that the clinical impact was high in approximately 80% of the patients, leading to further investigation, surgery, biopsies, etc. for the actual which may change their management or changing their antibiotics or antifungals, and with 64% of them actually changing their antimicrobial management. So the clinical impact is high within them. We have just a couple of examples. 16-year-old girl who had swelling, joint pain, fever and postural hypertension with associated neutropenia. The patients that we have done have been ones that have not tended to have their answers on conventional imaging, so that we have a smattering of patients that have been difficult for the clinicians to sort out. This girl was found to have hypermetabolic lesion in her chest, which was subsequently found to be a thymoma, and with splenic activity and lymphadenopathy that was FDG avid, and she had a thymoma with SLE associated syndrome, had a thymoma resected, and she improved for a while, but then her symptoms recurred, came back and had a very similar PET with still ongoing FDG activity within her spleen and lymph nodes, then went on to autoimmune therapy for her SLE and is now improved and clinically normalised. Another teenager with a very similar story: fever, weight loss, elevated inflammatory markers. She'd had an oncology workup and a infectious diseases workup, which to this point had been negative, and so it came to us with it for an FDG PET MR, and hopefully it projects well enough. You can see a little bit of patchy uptake within her muscles here. She's got abnormal MR signal on her coronal stir sequence. She's got evidence of bursitis, and she has evidence of FDG uptake within her brachial and radial arteries, femoral arteries, popliteal arteries, and so she's evidence of vasculitis, myositis, which was thought to be an inflammatory condition, and so the clinicians went back and asked her more history, and she was on minocycline for her acne, and there's a polyarteritis nodosa type drug reaction that can be associated with minocycline. So after having 4 months of weight loss and feeling poor, she stopped her anti-acne drug, had a short course of steroids, and was better within 48 hours. Another similar 12-year-old story with loss of weight, prolonged fever, but this child had granulomas within their neck that had been biopsied, but without being culture negative, I should say, and they had been thought to have. Oops, that's way too fast. So you can see here we have very FDG avid lesions within the neck, but there's also gut activity, there's peritoneal activity, and in Melbourne we don't have a lot of TB, and this is a patient without any, they were born in Australia, born in Melbourne, with no overseas travel and no TB contacts, but this led to the sampling of their peritoneal fluid and resampling of their cervical lymph nodes, and were found to have TB, which is relatively uncommon for us. And just moving on to a completely unrelated topic. So hyperinsulinism is another non-oncology cause that we have had studies for. So we've got a 5-week-old child who had intractable hypoglycemia with high dose insulin, glucose infusions on octreotide and a glucagon infusion to maintain their sugars. that found that they had an ABCC8 mutation, which is a problem with the ATP-dependent potassium channels and it's associated with focal hyperinsulinism. And so they had an 18F DOPA study looking for focal disease. And you can see intense uptake of DOPA within the head of the pancreas, which is nicely, the rest of the pancreas was macroscopically normal, although bulky on MR. And they were able to have a localised resection, develop transient diabetes, but then that settled over time and they subsequently went home with normal glycemic control. So, in conclusion, non-oncologic PET-MR we have found very useful. It provides diagnostic accuracy in epilepsy patients that are referred for the surgical program. It limits the need for multimodality investigations in fever and allows the definitive diagnosis in certain cases. Has a high impact on the patient's management and importantly allows for a markedly reduced radiation burden on these patients and a reduction in other imaging encounters. We, as a unit, now need to quantify our actual studies and our experience more significantly, but and particularly our epilepsy surgical program outcomes with time. And I just want to thank the rest of our team, some of whom are in the audience.
Thank you, Peter. Amazing images, and I think particularly the epilepsy surgery program at your hospital has been brought forward in leaps and bounds with that sort of amazingly high quality imaging. Any questions for Peter? I know it's late. I might ask one, maybe two quick questions. The setup with the coils looks quite elaborate and is a problem. So do you get blowouts in the uptake times, or do you inject and then start getting them on? You know what I mean? It just, I'm asking workflow issues,
yeah,
I guess.
No, we inject them and then start putting them on after they've had their significant uptake time. So the majority of uptake is done within 30 minutes, as you know, and then we put them and we try and image them around about at an hour, but we try and be preparing them at that time. But we do have significant variation in our uptake times, so sometimes depending upon the patients and how cooperative they are and whether they're awake or not, our uptake times are quite variable.
Maybe more relevant to the whole body scans, the heating of the patient, has that caused clinical worry at any point?
Not clinical worry, because our technologists are certainly watch, but we have to interrupt studies and rest them at times. So often we will do our screening MRs and then they will have a break, a significant break, before they then might go on to have dedicated MR region imaging. So it does create time issues. So
there's a threshold, presumably.
And comfort issues.
There's a temperature threshold at which point you'll say, just rest?
Yes. Technologists might be able to answer that more than I, but
okay,
yes,
they
talk to them. They're in constant communication, and it's about comfort and also their specific absorption rate that I think the scanner actually tells them how they're going.
You do or you don't do simultaneous EEG monitoring with the PET-MR?
No, we don't. No.
And how has that impacted your interpretation?
We're trying to do it in a interictal state, but you can never really know. So that creates, I suppose, an element of uncertainty. But
because when we do the PET-CT for epilepsy, we correlate with the simultaneously acquired EEG, and sometimes children have very subtle seizure activity with hypermetabolism, and without that simultaneous reading, there is no way that I think that just looking at the patient, especially with the technologists who are not that familiar with the appearance of seizure activity, it can be really difficult.
Yeah, it can be difficult, and I acknowledge that. Yeah.
One question, Peter, do you think there's any role for new agents that might cause hotspot imaging in these patients rather than FDG cold imaging, or do you think the field is now mature?
think it would be nice to have hotspot imaging with a good target to background ratio, but and I'm sure that with time that will evolve, but we have no experience with that.
Okay, thanks again, Peter, and I'll draw this session to a close, and we're just a few minutes ahead of time, so thanks everyone for their participation.